Hyperhidrosis. Hyperhidrosis is excessive sweating beyond what is required for the thermoregulation. This often leads to social, emotional, and professional impairment. This condition represents an overactivity of the sympathetic nervous system that leads to overstimulation of the respective eccrine sweat gland. Primary hyperhidrosis is bilateral, symmetrical, and focal involvement of the palm, soles, feet, axilla, and craniofacial lesions. The primary hyperhidrosis occurs in 1 to 3% of population. Secondary hyperhidrosis is more generalized and is associated with underlying medical condition or a pharmacological use. As such, the symptoms that present later in the life merit workup for the secondary causes. The most common causes of the secondary hyperhidrosis are excessive heat and obesity. Thyroid and other neuroendocrine disorders need to be excluded. Other potential causes include alcohol use, chronic heart failure, gustatory response, psychiatric disorders, substance abuse or use, and diabetes and other medical conditions. Diagnostic features of primary hyperhidrosis include excessive sweating for more than 6 months, axilla, palm, soles, plus minus facial involvement, bilateral and symmetrical sweating, absent nocturnal sweating, onset of less than 25 years or less than 25 years of age, and a positive family history. So areas could be focal, regional, or generalized, symmetrical or asymmetrical, and could be primary versus secondary, and type of sweating, anhidrosis, euhidrosis, and hyperhidrosis. So causes of generalized hyperhidrosis: drug, toxin, substance abuse, cardiovascular disorder, respiratory failure, infection, malignancies like Hodgkin's lymphoma, myeloproliferative disorders, cancers with increased catabolism, endocrine metabolic disorders, thyrotoxicosis, pheochromocytoma, acromegaly, carcinoid tumor, hypoglycemia, and menopause, and rarely idiopathic and primary hyperhidrosis. So localized hyperhidrosis could be idiopathic or primary. Social anxiety disorder, eccrine nevus, gustatory sweating, Frey's syndrome, impaired evaporation, and stump hyperhidrosis after amputation. Diagnosis of the primary focal hyperhidrosis: the focal visible excessive sweating of at least 6 months duration without apparent cause, with at least 2 of the following characteristics: bilateral, relatively asymmetrical, impaired daily activities, frequency of at least 1 episode per week, age of onset less than 25 years, positive family history, and cessation of the focal sweating during sleep. Diagnostic workup include history, age of onset, location, trigger factors, review of the symptoms, physical exam, lab evaluation, and starch iodine test. Once the diagnosis of the primary hyperhidrosis is established, patients are managed in stepwise fashion, starting with the least invasive therapy. This includes antiperspirants with 20% aluminum hydroxide in ethanol, aluminum tetrachloride. Potential drawbacks including the need for continuous use, dyspigmentation, and in some contact dermatitis. Tap water ionophorosis is reserved for patients with palmoplantar hyperhidrosis. An 85% rate of ionophoresis success has been reported by multiple series in those with focal palmar and plantar hyperhidrosis. The drawbacks include the labor intensity, cost, skin irritation, and the pain associated with daily treatment. Botulinum toxin injection can be used in the case of axillary hyperhidrosis, and they work by blocking acetylcholine esterase release from the presynaptic junction or the autonomic neuron, leading to the reduced eccrine gland sweat production, and relief of temporary and repeat treatment are required for 3 to 4 months and tend to be associated with pain as well as transient hand weakness. If topical measures fail, the systemic anticholinergics like glycopyrrolate, propanthenol and oxybutynin can be employed. Potential side effects include xerostomia, blurred vision, urinary retention in those with known emotional triggers. Beta blockers, benzodiazepine have been used with some short-term reported success, but the long-term treatment is discouraged as it can lead to profound rebound hyperhidrosis. Reports of other emerging non-surgical options, microneedle radioablation and microwave thermolysis, have been promising, but these modalities remains investigational and have not been adopted into the common clinical practice. Endoscopic thoracic sympathectomy is the treatment of choice in patients with primary hyperhidrosis. Endoscopic thoracic sympathectomy, the goal of the surgery is to interrupt the transmission of sympathetic nerve to the respective eccrine sweat gland. The key to success is the patient selection. Ideal candidates include the patient with early onset of primary hyperhidrosis. Given surgery is not done, the absence of the quality of life will not improve. The major risk factors include non-success of compensatory hyperhidrosis, need to be discussed in the preoperative consultation to establish the appropriate expectations. Those with isolated Palmer or Palmer axillary hyperhidrosis tend to be more satisfied with the surgical hyperhidrosis. The procedure is performed thoracoscopically with a double lumen tube, and the thoracic sympathetic ganglia are identified over the neck, ribs, and superior aspect of the posterior chest wall. Division of the sympathetic chain can be performed through the transection, resection, ablation, clipping. There is no clear advantage of one method over the another, and a long enough separation is made to prevent the nerve regrowth. The level of the intervention depends upon the region of the hyperhidrosis. A rib-oriented nomenclature is used to describe the anatomic landmark above which sympathetic chain is disrupted. The complete division of the sympathetic chain, including the accessory parallel chain of nerve of Kunz, at the respective level should be performed and separation is verified. Patient is isolated. Palmer hyperhidrosis represents the largest group of the surgical referrals. The R3 sympathectomy at the top of the rib should be performed in the cases of making sure to commence away from the stellate ganglion to prevent the inadvertent injury and subsequent Horner syndrome. The most common complication of the procedure is compensatory hyperhidrosis involving torso, thighs, and the leg. The risk factors for development of the compensatory hyperhidrosis, including multi-level sympathectomy, axillary hyperhidrosis, BMI 28 kg, and being 25 years of age. The division of at or above R2 levels and CH is greater than 40% of the patient. Other complications include Horner syndrome, bradycardia, chylothorax, and excessive dryness of hand. So for facial blushing, the target is R2, craniofacial is R3, Palmer is R3, auxiliaries R4 and 5, Palmer axillary R4 and 5, Palmer axillary and plantar R4 and 5. So the treatment response of division F above the R2 level leads to CH in greater than 40% of the patient. Other complications that can happen is Horner syndrome, bradycardia, chylothorax, and excessive dryness of the hand that should be taken into account. The primary focal hyperhidrosis is separate and unique disease, and bilateral symmetrical axilla, palm, soles, and craniofacial onset of the childhood, and significant impact on the quality of life and effective therapy. The complex regional pain syndrome describes the chronic neuropathic pain that follows the soft tissue of bone injury or causalgia. Type 1 is associated with soft tissue trauma. Type 2 is associated with nerve injury. Treatment is multimodal and includes the combination of medical, physical examination, sympathetic block, neuroaxial analgesia, and neuromodulation. And sympathectomy may be considered in patients with refractory cases. For severe cases, the first rib resection may be performed either via transaxillary or posterior approach. Transaxillary approach is preferred with the posterior thoracoplasty type of incision is reserved for the recurrent cases. Unfortunately, the progress is difficult to predict in some cases, and the complex regional pain syndrome may progress to involve other areas of the body. Thank you.